how easy it stayed there on my instrument as I moved it in there. We lightly pack it into the defect. We don't want to compress it too much because we want to leave space for the blood vessels and the cells. And then we just clean things up. We're going to close the flap. And then placing some of the vehicle on the soft tissue after flap closure. So let's talk a little bit about what's happening between this point and where we're at now after the video. As you saw a while ago with the controls, there's a lot going on in this defect. This is not a passive material that we're placing in there. And let's focus on what's happening at the interface between the root surface and the material that we just placed in the defect on the video when we think of mechanism of action. With the beta-tricalcium phosphate, it physically fills the bone defect, as you saw, provides a biocompatible osteoconductive scaffold for bone formation, prevents soft tissue collapse, and facilitates a stabilization of the blood clot. And as you saw in my clinical examples, it's a powerful active control. It by itself does a pretty good job. But that's not the only thing that we have going on here. We also have the recombinant PDGF, which is mitogenic. It stimulates PDL in bone cells, and it attracts PDL in bone cells into the site. And it also has some interesting angiogenic components. It stimulates and facilitates the ingress of blood vessels into this area. So we have a lot going on the cellular level at the bone to graft interface. The PDGF is stimulating, recruiting the cells in the area, bringing in cementoblasts, bringing in osteoblasts, fibroblasts, endothelial cells into the defect, and then initiating the process of regrowing the attachment apparatus. We're getting formation of new bone, new cementum, organizing PDL fibers, and if we look at my reentry here at 11 months, we're now getting a consolidation of a new attachment apparatus. When we look at the progression of what we started with to what we had at the end of surgery to my reentry at 7 months, a couple of things strike me. One is that if I look at a defect like this, I would think as a clinician that regardless of what material I place in there, I can probably fill that intrabony component. That's a type of lesion that you and I know that we can treat fairly predictably. What I wouldn't think I could probably do is fill this component of it, the suprabony component of this lesion. Yet, if you look at where we placed our graft and where we ended up, we were able to fill this beyond that point in the lesion. We grew that portion up. And so as a clinician, that really struck me, that I was surprised that we could fill that portion. I was also surprised and was consistently surprised at the hard cortical nature of the bone that we were regenerating here, with this reentry happening to be at 7 months. Another one of our patients, kind of a shallow 2-3 wall defect, debridement, placement of the graft, and at a year we've got 5 millimeter probing depth reduction and a 3 millimeter cal gain, which is very typical to what the study showed. You've seen this slide a couple of times this morning. I won't dwell on it. Basically what we found was that at 3 months, the 0.3 milligram group was statistically significant over the TCP, and that gain was maintained over the 6-month period. A more interesting way to look at it is looking at cal gain, which is called cal under the curve, which is a common way to look at wound healing studies. It allows us to compare different groups over time. And I think the take-home message here is that the PDGF appears to cause more rapid cal gain, and then that cal gain is maintained over time. Again, if we look at one of our cases, you see the defect initially, you see some calculus on the root surface. Here is at 24 months, very nice consolidation of the bone at 24 months. We have a 6 millimeter probing depth reduction during that same time interval. Another one of our patients, 6 millimeter probing depth reduction at 2 years. Again, you see the defect radiographically initially and what we have at 2 years. Very nice radiographic evidence of bone fill in that area. Another patient with a very deep defect radiographically and the appearance at 2 years. This was very common to what we saw in all of our patients, where we have our initial defect. At 3 months after treatment, radiographically, you're not seeing much change. At 6 months, we're beginning to see some consolidation of the defect. At 12 months, we're starting to see a little lamina dura, even more so at 18 months. And here at 24 months, we're actually seeing a little peak of the bone coming up toward the CEJ. Now, these are my patients, following them out over time. In the study, we only followed them to 6 months, and the radiographic evidence was generated from the baseline and the 6-month radiographs. They were sent and examined in a blind way, and were looked at linear bone growth, which is a change in the distance from the CEJ to the base of the defect from baseline to 6 months, and also looked at percent bone fill. This is linear bone growth divided by the defect depth at baseline. This is not a volumetric change, it's a two-dimensional change. And what we found was that radiographic linear bone growth was highly significant at the 0.3 level, above the TCP alone, and outperformed the 1 milligram per ml as well. If we looked at the radiographic percent fill, this is the amount of the defect that was filled at 6 months. Again, the 0.3 milligram outperformed the other two, and on average 56% bone fill at 6 months. One of the slides that I thought was very revealing is that the study stratified the defect classifications. All of us know it's much more difficult to regenerate 1 and 2 wall defects than it is 3 wall defects. And that's what played out, that if you look at the 3 wall and circumferential, all 3 of these bars are higher than any of these bars. But even in the easier to fill 3 wall defect, look how the 0.3 milligram per ml outperformed the other 2. And even in the more difficult to fill 1 and 2 wall defects, the 0.3 milligram per ml was highly significant over the other 2 defects. And even in these difficult defects, we got 53% bone fill. If we look at the proportion of cumulative bone fill, this is an interesting slide as well. You've seen it once this morning, but I think it's worth talking about again. This is the buffer alone, and this is the 1 milligram per ml, and this is the 0.3. You see how each one of these are clearly separate from the other. And at any point on this curve, no matter where you look, the 0.3 milligram per ml outperforms the other 2. This type of graph helps speak not just to statistical significance, but also to clinical significance, because 50% of the patients that received the 0.3 achieved at least 50% bone fill, where 50% of the patients that received the buffer achieved about 20% bone fill. And that speaks to what percent of the population actually have experienced a significant benefit. And clearly, the 0.3 milligram per ml group experienced a significant benefit. And if we go back and we look at the same patient that I showed you the radiographs, and we do a reentry, we see at 12 months we have 4 millimeter bone fill. Again, look at the hard cortical nature, the way the bone looks here at 12 months, a very, very nice result, and one where we're generating bone above the osseous crest, not just filling in the defect itself. So to summarize the pivotal trial, again, this is the largest prospective randomized human clinical controlled trial ever performed on a regenerative product in periodontics. If we look at the recombinant PDGF plus the TCP, there was statistical improvement at Cal gain at 3 months and Cal area under the curve between 0 and 6, interpreted as more rapid Cal gain, and then that Cal gain is maintained over time. Also, significantly more linear bone growth and percent bone fill at 6 months, just another one of my cases showing radiographically these changes. And while those are the results of the 6-month trial, my personal feelings are, and how I have experienced this in our office, is number one, it's a very easy material to use. It's not hard to deal with. I was impressed with soft tissue changes. The tissue heals very rapidly with this. Our Cal, our probing depths, our clinical attachment levels are maintaining well over time, and we're now to 24 months on all of our patients. And especially the radiographic changes were very interesting. You know, it doesn't take some complex mathematical formula to determine if there's something positive going on here. The radiographic changes are very dramatic. I'd also like to share with you a pilot study that we've just completed using a synthetic growth factor and a scaffold versus plus a collagen membrane versus connective tissue to cover root surfaces. You know, all of us would love to find some sort of material that we don't have to go to the palate in order to cover root surfaces. Just to give you a feel for what we're doing, this is a control on one of our patients, you know, fairly broad, deep recession defect, taking our preoperative measurements. This happens to be the control side. I've root planed and scaled. I'm placing connective tissue graft over these two roots. In the study, we won't allow two teeth to be together, but on the pilot portion we did. And I've currently advanced the tissue over my connective tissue graft. And here's what we see at 3 months, getting very nice root coverage over our lateral incisor and our canine. Here's the same patient opposite side, our test tooth, intraoperative measurements, root plane and scale, intraoperative measurements after flap elevation, and now we're delivering the growth factor, placing the scaffolding, which will provide space for regeneration, just comparing the thickness of the collagen membrane to the connective tissue that we're using. We trim the collagen membrane, place it over our scaffolding and the synthetic growth factor, elevate the tissue over that. Here's what we have at 3 months with our growth factor, and you can see very nice root coverage compared to what we had before. Also note the apparent increase in the amount of keratinized tissue over the root surface compared to what we had at baseline. If we follow the test control to 6 months, this is our connective tissue graft, and this is our test graft using the growth factor and the matrix. And I'll leave it up to you as to what you think about those two. I just share one more patient. This is just the 3 month with, this is the connective tissue, very typical look connective tissue at 3 months. This is what our test looks at 3 months, same patient, opposite side. And if we compare the two at 6 months, again, this is the connective tissue, very nice root coverage, and this is our test graft. And if we look at both of those, the things that strike me with both of these patients is the amount and predictability of root coverage that we're getting with our test graft compared to the control, our test graft compared to the control. Look at the soft tissue contours on the test graft as opposed to the flatter type contours that you typically get with the connective tissue, and also note the increased amount of keratinization or keratinized tissue that we have with our test grafts. You know, one of the things that makes the connective tissue graft appealing to a lot of clinicians is the fact that we do have a nice zone of keratinized tissue. Lots of the other grafts that we see where we're trying to find other ways that we can graft over these root surfaces just don't yield the keratinized tissue that we as clinicians like to see, and certainly we're seeing that in this. So we hope to take this pilot study now and move into a study that will start shortly after the first of the year with 30 patients, and hopefully next year we can provide results on that. Let's move from using bioactive molecules to using living cells. And before I talk about our study, I need to recognize the work of Dr. Bausma and the University of Texas Health Science Center in Houston, the dental branch in Houston, for their work showing safety using autologous cultured fibroblasts. We took this safety information then and moved it into our trial. We are currently, we are about 5 months into this trial, And so I'm going to share with you my impressions and give you an idea of what we're doing, but I don't have data, but I think it's worthwhile to share nevertheless. You know, one of the last frontiers in periodontics is being able to regenerate that papilla. Nobody can show you on a predictable basis that they can do that. Lots of people will show you, you know, here's a clinical case, but nobody can show you time after time. And so what we're trying to do is to use a novel approach. It's a patented technology in which we're injecting the patient's own cultured and expanded fibroblasts into that papilla. We take a small biopsy. The biopsy is then sent to the laboratory. From that biopsy, the fibroblasts are extracted. They're reproduced and grown and then placed in an injectable medium. We take then the patient's living fibroblasts, we inject them into the papilla. The fibroblasts then produce collagen and expand the tissue. So what we're talking about here is not injecting a filler. We're not injecting collagen. We're injecting living fibroblasts that then produce collagen to expand the tissue. You know, we're just beginning to understand the complex intracellular interactions between gingival fibroblasts and their relationship to the structure of the periodontium. They're much more than these mundane little things that I learned about in dental school and later in my periodontal training. Gingival fibroblasts have a great deal of phenotypic heterogeneity and theoretically can contribute to regeneration through they're supplying undifferentiated mesenchymal cells. You can get more UMC cells from gingival fibroblasts than you can from dermal fibroblasts, and given the right stimuli, those UMC cells can transfer into bone, cartilage, a number of tissues. So in our study, we have 20 patients, 118 total test and control sites, but we have 40 matched randomized test and control sites, meaning we have 2 primary test and control sites. We've tried to match the defects, and then we have a lot of other sites to allow us to collect more data. Our primary endpoint is change in baseline from the papillary height to the base of the contact area, and we're measuring that with a probe. We're also making models both at day 0, at 4 months and 12 months, and coming in and measuring them with a digital caliper. We're also interested in hard tissue changes as well as soft tissue changes because theoretically these fibroblasts could influence hard tissue changes as well. So as secondary endpoints, we are looking at change from baseline from the distance from the tip of the papilla to the alveolar crest